So let's go for the hidden side of the drug-coated balloon. It's not all positive. Sometimes we have some complications, some rare, some are common. So let's discuss the case together. So this is my case. He's elderly patient. Remember well, this is 85 years old gentleman. This patient had diabetes, hypertension, dyslipidemia, and he is non-ischemic heart disease since long time. PCI to the circ, more than 15 years. PCI to the RCA in 2017. Patient came, acute coronary syndrome, non-STEMI, admitted, next morning taken to coronary angio. So we have found that the two stents of the RCA 2017 still patent, which is good. LAD had diffuse disease, but no significant lesion, and it seems that the culprit is in the circ. Patient had two previous stents in the circ. The proximal one has some in-stent restenosis, but the distal one showed more significant disease. And remember, this is 15 years old stent. So let's focus on the circ. You can find proximal stent followed by mid-segment stent. The distal stent is looking to have significant lesion, which looks like the culprit. So PCI strategy, let's make it simple. This is 85 years old. Let's have pre-dilatation followed by drug-coated balloon, and this is mainly for the distal lesion. I think this proximal lesion is borderline. I may even go medically with this. This is the initial strategy. So I started by NC balloon 3012, dilated nicely, and I had a stent-like result. Oh, it's my lucky day. So let's go for the drug-coated balloon. I selected the drug-coated balloon at 3015, sequence please, the most commonly used in my center, and inflated for 45 seconds as usual. But during balloon inflation, the patient developed severe chest pain with ST segment elevation, which is normally we can see during balloon inflation. But what is unique for this patient that the ST segment elevation and pain remained while after the deflation of the balloon. So let's have a quick angio, and this is what I found. There is no reflow in the circ. I totally lost the flow in the circ. So what happened? This only happened after the drug-coated balloon. So what is this? Why this happened? It is air. I am sure there is no air inside. ACT was controlled. I did not have dissection. This is balloon inside the stent. And what is more important, what shall I do? So what I did is, let's try to clear whatever there. I took the manual thrombus aspiration 1, 2, 3, 4 times, and let's see what happened. I have some yellowish debris from outside. I did not have the flow distally restored yet, and you can appreciate some worsening in the flow in the proximal stent as well. So this is not only thing. Angiographically, the patient started to have more ST segment elevation, and as you can see, the patient started to have hypotension. I'm feeling that I'm losing the patient. He is screaming, he is in pain, hypotension, ST segment elevation. So, what to do? Okay, let's back to basics. Let's have a balloon, do this mechanically, NC balloon 2.5, and dilate all my way in the circ till I understand what is going around. So balloon here, balloon there, and I could restore the flow. So the patient now has less pain. Patient has resolution of ST segment elevation. Now I could breathe. The patient is happy, but
Do you know the ACT?
yeah, ACT was normal, more than 300. So with this, I still have challenges. The patient looks fine, but you can notice at the distal of the stent, I have some haziness at the distal, just distal to the stent where my balloon touched. And I have this compromise in the OM, which was not there in the start. And much more important, I have a filling defect at the mouth of the circ, which was not there from the start. So before discussing with my colleagues what to do, I will plan, and then all of the sudden patient develop again severe chest pain, another no reflow, and there is another re-occlusion in the circumflex. So what to do now? Okay, let's fix whatever down. I will use a drug-eluting stent. I will cover the gap between the two stents just after that OM, and I will stent the old stent with the new stent. And then the stent looks better, but still I have a third no reflow. You can notice the flow down is not that much great. So another manual thrombus aspiration, which could improve partially the distal flow. And then I had this question, what should I do for the ostial circ? Should I do more thrombus aspiration, stent, tyrofibin, or imaging, or coronary mechanical thrombectomy? And this was my choice. I went with Penumbra. Is in a single run. It was like magic, and I got clearance of the circumflex. Now I have a flow, patient is happy, no more S-segment elevation, but from the tip of the catheter and even from the Y connector, I could have this piece of tissue. It is not a thrombus. I have something on the table which is not a thrombus. So I sent it to histopathology, and the result came later. It showed lipid-rich soft tissue with bluish foreign material mixed with fibrous thrombus. So let's forget about this. Come back to my case. I have complete resolution of ST segment elevation. I optimized the balloon, and I have a good, very good result for the stent. OCT confirmed the good stent deployment with clean area at the mouth of the circumflex. And this is my final shot. So, what went wrong? What happened? Why we have this scenario? My understanding, and this is what I proposed, I have this new intimal tissue embolization. Sometimes this old stent, more than 15 years, it's not in stent restenosis that this mechanical factors. There are new tissue and aggressively dilatation in this area. It will allow this to distal embolize, and this is not a thrombus. It will have a tissue distal embolization with resistant Reflow. It can go and hang in the vessel and cause this. So it is mainly new tissue that is broken by aggressive predilatation and went down and up. And there is a distal edge dissection which was sealed. Then I followed this patient with this good result angiographically. 1 year follow-up, the patient did great. I found the publication with a similar story that new intimal embolization causes a very bad type of Reflow. My take-home message, new atherosclerosis is increasingly recognized mechanism of late stent thrombosis, late stent failure. Detachment of new atherosclerosis can cause unrecognized vessel occlusion. And this is very important message. Aggressive dilatation to correct mechanical in-stent restenosis in a patient who did not have mechanical issue. It's 17 years old, stent now. This is a state of mind. It's a revenge state of mind. This aggressive dilatation is associated with sometimes a kind of Reflow that is very resistant. My take-home message, do a stepwise dilatation, image-guided, to avoid such complication. Thank you very much.